Hello, everyone, and thank you for joining the RBM SBC Working Group July General Call. I see that participants are slowly joining, so we will give them just a few more seconds to get online with us. If this is your first time joining the working group, my name is Gabrielle Hunter, and together with Miriam, we are the co-chairs of the SBC Working Group. The SBC Working Group Steering Committee and Secretariat welcome you to today's July General Call. This is our third and final call of 2022. You can follow the presentation slides in English, French, or Portuguese by going to the link that's here on the slide and is also in the chat box. As always, the Secretariat will send the slides and recordings in all three languages by email after the call. So if you haven't already done so, please go ahead and introduce yourself in the chat box now. Make sure that you select all panelists and attendees before you type, before you send your message, so everyone can see your introduction. And finally, don't forget to select your language for interpretation at the bottom right-hand corner of the screen. Please go ahead and do this now. I'm seeing many familiar names and names in the chat and others joining. Welcome, everybody. Thank you so much for joining us today. I'll now pass the floor to Ashley from the Secretariat, who will begin today's agenda with a few updates from the working group. Over to you, Ashley.
Thank you, Gabrielle. I am pleased today to provide a few updates on behalf of the Secretariat and the Steering Committee. First, please join me in welcoming a new member of our Secretariat team, Eva Rosen. Eva is a program specialist with the Johns Hopkins Center for Communication Programs. Please reach out to Eva via email or on Springboard as another way to engage with the WG Secretariat. Eva joins me and Jean-Jacques Bro, who is based in Abidjan, on the Secretariat team. Please join me in welcoming Eva in the chats. Welcome, Eva, and thank you so much for joining the team. For our second update, I am happy to share that planning is well underway for the SBC Working Group's virtual forum on September 21st and 22nd this year. The forum will be held on Zoom, and we are developing an exciting agenda, which will include technical presentations, updates on our workstream activities, discussions about the future directions of the SBC Working Group, and updates from other RBM working groups. Thank you to everyone who submitted an abstract. You'll be hearing from the Planning Committee soon. If you haven't already, please use the link in the chat to register for the virtual forum. Next, Steering Committee elections will commence in October. There will be 2 co-chair positions and 4 Steering Committee positions open for election. The Secretariat encourages everyone to review the SBC Working Group's Terms of Reference, which outlines the eligibility criteria for both co-chairs and Steering Committee members. The Terms of Reference are available in English, French, and Portuguese, and the link is available in the chat. Finally, I'm pleased to share that the SBC Working Group has officially launched our newest work stream, which is focused on malaria SBC during RTSS malaria vaccine rollouts. The work stream will build on what we learned and discussed during last year's virtual forum. The work has already started by capturing learnings from RTSS pilot experiences as well as COVID-19 vaccine introduction. The team will also review reports and hold key informant interviews. Finally, the proposed deliverable includes a guidance document for SBC during RTSS vaccine introduction. This is a wonderful opportunity to get more involved in the working group, and workstream participation is one of the eligibility requirements. for steering committee positions during our next election process. If you are interested in joining this work stream, please share your information with the Secretariat through the volunteer form, which is linked in the chat. Thank you to everyone who has volunteered already. You'll be hearing from the Secretariat soon. I will now pass the floor to Susie Emiliano and Ida Savadogo to share updates on the Lusophone and Francophone Ambassador Program. Susie, the floor is yours.
Obrigada, Ashley. Boa tarde a todos. O meu nome é Suzy Emiliano e eu sou...
Thank you, Ashley. Eu sou uma das embaixadoras lusófonas, Lusophone in this group, thank you, together with my colleague, Sérgio, so about the program in malaria in Mozambique, and Deborah Freitas, who is our point of contact for the Lusophone ambassadors. I prepared a brief update about what we have been doing in our group right now, and would like to share that we have other 2 of June, we have our first session, a networking session with other Lusophone members of our group. We were able to have 18 members, which was quite a very encouraging number. And we have our official opening with the national coordinators about the malaria in Angola and Mozambique. Dr. José Martins from Angola explained us how the communication should be valuable or should be taken into account as a pillar or as a important to achieve the objects of malaria. And then he also explained how he appreciates our Lusophone network, and this sharing of information is very important within the SBC with all Lusophone countries. Also, we also discussed the role of the ambassadors, and as well, we talked about the protocol, the springboard, explaining our participation within the Lusophone community in the springboard. Later on, we had a debate about with all the countries together connected with us. We would like to have a very active participation of all Lusophone members, and those who would like to do that, please join us on our WhatsApp group, which is online, and also retrieve all our contacts of Deborah and Sergio in case you want to reach out to anyone else. This is very important for us for our working group on social behavior change about malaria. This was a update that I had about the actualization of our Lusophone Ambassador Program. Now I pass the floor to my colleague Ida, who will do an update on the Francophone Ambassador Program.
Unfortunately, I think we lost Ida's internet connection.
Hello.
Hello, John. Go ahead. Thank you so much.
Yeah. Bonjour à tous. Bonjour à tous.
Hello, everyone.
Bonsoir, ça dépend de là où vous êtes. Je vais donner rapidement quelques informations.
Good evening if you are in another country, and we would like to give you a couple of updates. And what we did for us in our group, we created a group of ambassadors so that we could coordinate the different working groups in a regional level. So the Francophone ambassadors are volunteers from the working group, SBC working group. Our ambassadors are professionals in different countries, and they fight against malaria. And as you can see here, we have Jemima Mori Kamara from Mali. Jemima is from Madagascar. Ibrahima from Guinea. And Ida Savadogo from Burkina Faso. The ambassadors are also promoting activities and also resources for the working group, and they work with different networks. They help us promoting different activities in different countries so that we can have an important number of Francophone people joining. You can see in the slide, we have included the emails of the ambassadors, so you can contact them if you need help, if you want to join the working group, RBM working group. And now I would like to give the floor back. So thank you very much. And I would like to give the floor to Aviri. Thank you.
Merci, Avery.
Thank you,
Thank you very
Jean.
much. Please go ahead, Aviri.
Thank you, and hello, everyone. I'm Ava Verkatis, a member of the SBC Working Group Steering Committee. Today, I'm pleased to provide a bit of background before we begin our technical presentation, which focuses on provider behavior change. Provider behavior change and service communication are two areas where social and behavior change in service delivery overlap. Service communication refers to the use of communication approaches before, during, and after service delivery to boost service uptake and maintain healthy behaviors. Provider behavior change seeks to address behavioral factors that influence the way health providers carry out their tasks. These tasks can include diagnosis, treatment, counseling, reporting, supply chain management, and many others. For service communication, clients are the primary target. Service communication can include mass media campaigns, community dialogues, job aids, etc. Many of the presentations in our general calls fall under the realm of service communication. On the other hand, for provider behavior change, providers are the primary target for provider behavior change interventions. Provider behavior change interventions may involve both communication and non-communication elements. For example, it can involve a mix of provider group discussions, point of service materials, training, performance-based financing, supervision, and quality improvement and process changes. Provider behavior change interventions can be delivered by other providers, supervisors, and government or partner staff. Clients and community members can be involved in provider behavior change interventions if the objective is to influence provider behavior, such as through client feedback methods. Today, Dr. Stella Babaloa will share results from a health facility assessment in Benin. This presentation explores how psychosocial questions in health facility assessments can boost our insights on provider behavior and inform future provider behavior change programs. Dr. Stella Babaloa is a professor of health communication at the Johns Hopkins School of Public Health and director of the Research and Evaluation Division at the Center for Communication Programs. A demographer by training, she has more than 30 years of experience in behavioral research and has worked extensively in Africa, Latin America, and the Caribbean. She is a health communication and behavior change researcher and has published extensively on multiple health issues. Throughout her presentation, if you have any questions, please type them in the question and answer box at the bottom of your screen in either French, English, or Portuguese. Now I will pass the floor to Dr. Stella Babaloa. Thank you for joining us, Stella.
Thank you, Avery. So it's my pleasure today to share some data that we collected late last year in Benin to talk about the influence of psychosocial factors on provider fever case management in health facilities in Benin. Next slide. So let me give you a bit of background to this study. Malaria, in Benin Republic, malaria is endemic. The entire population is at risk of the infection. Malaria is a leading cause of morbidity and mortality and contributes to 47% of outpatient consultations in the general population, about half of outpatient consultations in children under 5, and about 39% of hospitalizations in children under 5. The most recent DHS 2017-2018 showed an increase of about 39% compared to 2011-2012. But prevalence of malaria varies widely across department, the regions, and Atakora in the northwest and Kofu in the southwest are the most affected regions. Next slide, thank you. Provider adherence to case management guidelines is critical. We cannot do without it. It's critical for effective malaria control. We know that provider behavior is complex. It is influenced by factors at the individual, at the interpersonal, at the facility, and at the system levels, as described in this breakthrough action publication, a blueprint for applying behavioral insights to malaria service delivery. Next slide. Psychosocial factors such as attitudes and norms and self-efficacy have been found to influence health behaviors in other areas. And qualitative research has shown us that these factors are influential in the case of malaria case management across settings. But little quantitative research has been done to measure the prevalence of these factors and to assess their association with provider behavior. Health facility surveys are commonly used to assess the quality of health services and related determinants. Adding a few questions about psychosocial determinants to such surveys could lend useful insight to programs seeking to improve provider case management behavior. Let me talk about the methods that we use in this study. The data that we are presenting today came from a health facility assessment conducted in Benin in November-December 2021. The sample included a random selection of health facilities from all the 12 department regions of the country. The assessment included interviews with facility managers from 128 health facilities, both private and public. Structured interviews with health workers from 366 health workers that are involved in malaria case management. And structured interviews with 1,245 patients with fever, all their caregivers when the patient is a child. Next slide. So today, the outcome of interest that we are looking at is correct management of fever, defined as performing diagnostic testing and appropriately treating the patient based on the results of the test. We use multivariable logistic regression to assess the association of provider socio-demographic and psychosocial characteristics, provider facility attributes, and client profiles with correct management of fever. We limited the analysis to 88 facilities with testing and ACTs available on the day of the study. Next slide. So let's go on to the results. As you can see from this slide, the greater problem appears to be with testing. Less than 2/3 of the suspected cases of malaria were tested. But then, once tested, most cases were appropriately treated. It is interesting, however, to note that about 20% of cases, the cases that tested negative received an anti-malaria, received an ACT. It is also interesting to note that more than half of untested suspected cases of malaria received an ACT. Next slide. This slide shows that correct management of malaria cases of fever varied by type of facility. One may want to note the relatively low level of correct management in hospitals compared to the other types of facilities, and particularly in private clinics. So let's look at the results of the multivariable logistic regression. I want to start with number 4 here in this slide. Perceived peer adherence is positively linked with correct management of suspected malaria cases. This indicates that providers' adherence to guidelines is dependent on what providers perceived their colleagues to be doing. This is a phenomenon known as conditional compliance. That is, people will follow the guidelines if they perceive that other people around them, their colleagues, are doing the same. And this is important to note because it has implications for programming. The data also show that training matters. Provider knowledge about case management also matters. We also see that compared to children under 5, children or young children ages 5 to 14 years are more likely to be correctly managed. And there is no difference in management of under 5 and children and older children and adults ages 15 and over. The data also showed us that the higher the prevalence of positive cases in the health facilities, the more likely it is that providers will abide, they will respect the guidelines. Again, that indicates that practice makes perfect. The more they do it, the more they continue to do it. The more they have the opportunity to do it, the more they continue to do it. And then the reverse might also be the case. The lower the probability that they will have the opportunity, the lower it is that they will likely adhere by the guidelines. Thank you. Next slide. We also have some additional results to share. The facility type, the odds of adherence were especially low for patients treated in private clinics. Providers' perceptions about clients were slightly more likely, the providers with positive perceptions about their clients were slightly more likely to practice correct case management. That is, providers that believe that their clients would adhere to treatment, that believe that their clients are demanding, that believe that their clients may question the provider's behaviors, are more likely to practice correct case management. In this study, provider attitudes towards case management were not associated with the outcome. So what are the conclusions and recommendations? There is need to pay attention to private facilities. We will need to understand what is going on and how can we better bring private facilities to the desired level of correct management behavior. It is important to monitor provider case management behavior in areas where malaria prevalence is low or where it is decreasing. Because like we said, practice makes perfect. What if now the cases are reducing? What is going to happen? We need to continue monitoring as malaria prevalence reduces and intervene appropriately. It is important to emphasize adherence irrespective of patient's age. Everybody, young or old, should be tested and should be appropriately treated based on the test results. We need to understand the reasons why providers are more likely to adhere to guidelines with young children 5 to 14 than with younger children aged less than 5 years. It is also important to empower providers to strengthen the capacity of patients to adhere to treatment and to position patient adherence as the norm. So this also speaks to service communication. Next slide. Thank you. So again, talking about the recommendations, provider behavioral change efforts can integrate approaches from SBC to intentionally, and I want to underline that word, intentionally, improve norms. This can be done by promoting discussion among providers, leveraging opinion leaders and professional networks, all site group-based interventions, as opposed to sending 1 or 2 providers out for training. So intervening at the facility level. All this will help to create a culture of correct case management within the facility. And these approaches are compatible with trainings. They are compatible with quality improvement initiatives and other service delivery interventions. Next slide, please. In conclusion, looking at case management through a behavioral lens is valuable. In addition to knowledge, factors related to providers' perceptions, factors related to clients, factors related to facility context impact case management. Efforts to improve provider adherence need to address these perceptions and other drivers of behavior. Next slide. So finally, questions about psychosocial factors are feasible. We can include them in health facility assessments, and they can yield useful data for informing provider behavior change interventions. Next. So I want to thank you all for listening, but I want to especially thank my co-authors. We are Matthew Pluzinski, Ruchita Pillai, Ortrans Kosu, Aurora Unto, Angela Costa, Jean Serre, Patrick Kondo, Vigil Nyageno, Ahmed Afsani, and Syriac Afuku. These are people from various institutions, including the HISA project in Benin, CDC, PMI, USAID, PMI, and most especially, and I really want to appreciate the collaboration that we've had with them, the NMCP in Benin. Thank you.
Thank you so much, Stella, for that insightful presentation. We can now take several questions about this work. So please go ahead and submit your questions in the Q&A box and comments in the chat box, and we'll go ahead and address those. Maybe to start, I think one question I have, Stella, if you want to address it, is can health facility assessments also be used to assess service communication?
Yes, the answer is yes, because we interviewed the clients on their perceptions about what they received, the information they received. Unfortunately for this study, we did not do observations. Okay, so that would have allowed us to actually observe the interactions between patient and but we can, based on the questions, we certainly can, and we did. At least at the facility level. It's also possible to include questions about what people are hearing outside of the facility in the provider, in the client interview, exit interview form.
Great, thank you, Stella. Another question for you, Stella. Do we need to better understand the reasons why providers are more likely to adhere to guidelines with children 5 to 14 years? Can you comment on what might be some bias or other psychosocial issue underpinning that behavior on behalf of providers?
Yes, thank you. So I would like to look at why is it that they are not adhering when it comes to the young child. I think it is because, I mean, this is just me saying this. I think it is because, of that belief that malaria is more dangerous in this population of children, the under 5. So that, they don't want to take risks, they don't want to take chances. They just want to, malaria, now let's at least, start by eliminating this. So I think they are probably over careful when it comes to under 5 children. Yeah.
That makes a lot of sense. Thank you. A question we have from Ferdinand. Have you explored the determinants of provider behaviors that in principle could be in decline in behavior change interventions?
Can you come again, please?
Not sure I totally, so have you explored the determinants of provider behaviors that in principle could be in decline in behavior change and interventions?
Decline in inappropriate behaviors?
Yes.
Okay, so for one of our findings, the fact that practice makes perfect, that the more people see positive malaria cases, the more likely it is that they would adhere. So I think that as our efforts start to bear fruit, as we, as cases decline, malaria cases decline, we will need to pay attention to what is it that providers who are not seeing as many cases as before, what is it that they are doing? Because that might have a negative effect on adherence. I don't know if that is the meaning of that question, but yeah, but that's something that I could say.
Thank you, appreciate that. Maybe just a clarification question, if you will. On providers performing malaria tests on suspected cases, were you referring to RDTs, microscopy, or both?
It will be mostly RDT, because it's not all facilities that have the facility to do microscopy. So for most of them, it will be for the majority we are talking about RDT, which is available everywhere, or it's supposed to be available everywhere, although it wasn't the case. Yeah.
Okay, great. And another clarification, was the provider's testing behavior self-reported, or was actually observed during the counseling session?
So what happens is, we actually, as part of this study, there was retesting. So the provider would give a note to the client stating what the result is and what the treatment was, and that the client will bring that to the interviewer, to the study team. Then the study team will record all of that, and then we'll redo the test to see, if indeed the test is exactly, the results are the same as what the provider found. So it's both, it's both what the provider actually says and what she gives to the client, to the patient, and based on the questioning from the study team. We asked whether this was done, but actually we could see whether it was done or not.
Thanks for that, Stella. And now a question from Pascal. Do you have any information on the determinants of non-compliance for providers in private training? Were they involved in all procedures?
Yeah, so you mean in private clinics? So that is actually the issue. There are plans, NMCP has plans to train providers in private institutions. But it is very difficult. I don't know to what extent those plans have been implemented before the survey, but there were plans to train them. The providers in private institutions. But again, also, it might also have to do with the level of basic qualification of those of providers in those facilities. It has to do with a lot, but we really need to dig deeper, maybe into the data, maybe also conduct some additional qualitative study to better understand what is going on there. One thing that we saw is that the level of correct management was very low in those facilities, and we need to better understand why.
Thank you. And just to follow up on that from Pascal is around private pharmacies. Did you notice any sort of trends with private pharmacies? Did they adhere? Did you look at that at all?
No, not at all. We did not go to pharmacies. We went to facilities that are, medical facilities, clinical facilities, not pharmacies.
Great, thank you. And now a question from Sean. Were you able to look at correct case management for severe malaria cases compared to simple malaria cases? If so, did you see any difference? Does correct case management include correct classification, simple or severe, as well in this study?
Unfortunately, no, we did not focus specifically on severe malaria. We asked questions about knowledge, provider knowledge about severe malaria, but that was not the focus of this study.
Thanks. And a question from Gabrielle. How can we leverage the fact that the perception of the behavior of providers' peers are influential in their own behaviors?
Yeah, so many things we could do, and I think we spoke about some of those in the presentation. Is what that is saying is actually that people are influenced by what is happening around them, and so the more we influence, the more we change positively what is happening around them, the better chances of succeeding will be. So again, it's about the norm. It's about what it's about what people perceive to be the norm. It's about what people believe their peers are doing. So it's about making sure that or ensuring rather that there is this facility norm that favors correct management. For example, that collective efficacy. For example, being able to say in a facility, this is the way we do things. And people are sort of socialized into that thinking that in this facility, you do this, you have to test. We do not treat without testing. Again, making it like a general disposition and everybody being involved, from the manager to the person that was just hired yesterday. Everybody having that mentality in a facility. This is the way we do things.
Mm-hmm. Thank you for that. From Tiana, a question. In other contexts, the number of clients waiting in line to be seen by the doctor influences the provider's behavior. Did that come through at all in the results from Medin?
Yes, it came through. It came through, but in other analysis that we are going to be doing going forward, we are going to be pointing those additional findings out. The workload really matters. The workload matters. The more, and that if I remember correctly, the larger the number of clients that a person still needs to see in a day, the more likely it is that they would compromise correct treatment. Yeah.
Great, thank you. A question from Augustine. What are the recommendations for providers who treated for malaria that had a malaria test result that's negative?
The recommendations will be to first of all understand why, and I believe that is because maybe they doubt the validity of those results. Maybe also, because this is RDT, they are thinking that, with all these other signs, this person does not have malaria because we have not done microscopy. So I think we need to increase their level of faith in the test results, and also maybe a better understanding of, the cost of treating malaria when malaria is not there.
And I mean, just following up on that, do you think there's specific approaches or strategies, SBC intervention approaches, that are would be more useful in achieving that aim?
Yeah, at this stage, I want to call on somebody like Gabrielle to intervene, but I would say that, yeah, this can be done as part of training. This can be done also, with job aids and all of that, that people have, because training is one thing. Training is one thing. They go for training, they are trained on the job and all of that, and then they forget. Or it's just something that is no longer top of their mind. But if they have job aids, if they also have, again, looking at, this is the way we do things in our facility. If they have support in the facility for appropriate behaviors, yeah, I think that would help. But maybe my colleague, Gabrielle, has something to say about that.
Oh, thank you, Stella. Maybe just one brief thought, which is that the intervention should try to leverage what the data is showing as being a powerful motivator to the providers in that context. So the results from this Benin study show that when the providers believe that other providers are adhering to the guidelines and they perceive that their peers are doing it, that it influences them to do it. So in this case of, in the question around providers treating for malaria, even when the test result for malaria is negative, perhaps an SBC intervention in Benin that really focuses on what their peers are doing and how other peers are not treating for malaria when the test is negative, and really try to apply that sort of pressure that the data shows as being influential and could have impact. And we've seen this kind of work done within health facilities through activities such as like monthly performance posters on the walls in facilities where performance data from nearby neighboring facilities are listed alongside their own facility data, and providers can see in real time or somewhat real time what providers in other facilities are doing. That's one example. We've seen other examples as well of ways to help providers better see what their peers are doing or not doing, and leverage that. And so I think in other contexts, similarly, trying to understand using data like this, if possible, what those really important leveraging factors could be, and then trying to implement those within the health facility setting could be helpful.
Thanks so much, Gabrielle and Stella. Appreciate that. Another question for you, Stella. Healthcare providers who are from low endemic areas might not have as many chances to provide malaria case management when compared with their colleagues from high endemic areas. Could that be a factor in why they don't comply or with the treatment guidelines in the same way?
Yeah, because we show the results show that the higher the prevalence of malaria positive test result, the more likely it is that the woman, that means the provider, will comply. So again, that speaks to the point that you are making, that in low prevalence areas, they might not have the opportunity to treat case management. And it might also be that, we tend to, programs might have a tendency of not paying as much attention to providers in those areas because this is low endemic, not knowing that, again, there are still cases in those areas. So I think that, going forward, one message will be that, pay attention to all regions and ensure that whoever has the opportunity to manage malaria, they know and they are convinced that, each case should be tested, each case should be correctly managed. Yeah.
Thank you so much. A question from Tay. Hearing this discussion makes me wonder if it might be a best practice to do a study prior to developing interventions for SBC activities with service providers. Could you comment on that?
I would say yes. I would say yes, because any interventions they are dependent on the context. Interventions should respond to what the problem is. And if we do not understand what the problem is, we cannot appropriately intervene and obtain results. So I would say yes. It might be qualitative research. It might be, maybe other people have done this, looking at existing studies and seeing what we can learn from existing studies. But, we want to have a better understanding of the context of what the behavior or current behaviors are, what the underlying factors are, so that we can then develop appropriate interventions. Yeah.
Thank you so much, Stella. And thank you all for the excellent questions. We will ask Dr. Babalola to answer any remaining questions. And we'll also include those in the recap email that we send out after the call. But I now want to pass the floor back to Mariam to close today's call. Mary?
Yes, sure. Thank you so much for moderating very well that session, and to our facilitator, Dr. Stella. We are always delighted to have you on this platform. You have very insightful findings, and what I am also picking from this meeting today is that as we are implementing our activities at health facilities, it is important for us to identify peer providers, and so we can deliver our messages through the peer providers, and they can also help us to lure other health workers. Thank you. There is so much for us to learn from that presentation. Back to closing this meeting, we are very excited that we have held our meeting today, our general call. Thank you everyone who has signed up for this meeting. I want to take this opportunity to appreciate our Secretariat and steering committee for preparing today's call. And thank you again, Dr. Stella, for the outstanding presentation on the important topic of today. Psychosocial factors are very important, and I want to request everybody to take this presentation seriously and look at it as we implement in our countries. Before we officially close today's call, I would like to share a recap of our June 30th webinar. We had a webinar that was giving us insights on the guidance for implementing malaria SBC with Zero Malaria Starts With Me. And this webinar discussed the areas of convergency and divergency between malaria SBC and Zero Malaria Starts With Me. And 5 recommendations were given, and we should always refer to them. They can help us to move forward without compromising the implementation of social behavior change. Remember, social behavior change is about changing individual and community behaviors regarding specific malaria prevention and treatment behaviors. And advocacy is about creating and enabling environments for policy, resource mobilization as well. So we need, when we are implementing that, to define clearly the benefit of social behavior change. I would like to also appreciate the speakers of that day from Ethiopia, Uganda, and Kenya for sharing their experiences. And if you have any experience to share, just get to Springboard and share your experience of implementation of Zero Malaria Starts With Me. The recordings of this meeting are available still on Springboard. Always refer to them in case you're going to implement your Zero Malaria Starts With Me. Don't forget to identify your behavior objective within that campaign. Lastly, I want to thank you again, everyone, for joining today's call. We would like you to complete a Zoom survey that will be shared by the Zoom into your browser. Thank you very much. We'll see you again in September at the virtual call. We appreciate you, and we are here for you in case of any questions. Thank you, and have a lovely morning and evening.